And so now our speaker, Dr. Medha Munshi, is an associate professor of medicine at Harvard Medical School, and she's a geriatrician and an endocrinologist. She practices primary care geriatrics at the Beth Israel Deaconess Medical Center and directs the Geriatric Diabetes Program that she developed at Joslin Diabetes Center. The primary focus of Dr. Munshi's clinical research is to identify challenges faced by older individuals with diabetes and to develop strategies to overcome these barriers to improve clinical and functional outcomes, including quality of life. Her recent research is also focused on successful use of diabetes-related technology in older adults with type 1 and type 2 diabetes. She has numerous publications on aging and diabetes and is also the founding president of the International Geriatric Diabetes Society, whose mission is to improve research and clinical care in older adults with diabetes. Welcome, Dr. Munshi. We look forward to hearing from you.
Thank you. Can you hear me well? Okay. So it's truly a pleasure and a little bit intimidating to present about de-prescribing to the de-prescribing gurus. I mean, you all are the expert and you have this whole network on de-prescribing. So I'm going to try and keep my thoughts on the diabetes and the de-prescribing in diabetes. And hopefully finish it early enough to get some discussion and your thoughts on what I'm presenting. So let's see. I think I was, let me see. All right, so here is my disclosure. I consult with Sanofi on the care for older adults. Rest of them should not be a problem. So my objectives for this perhaps 40 minutes was to sort of think about why do we need to consider de-prescribing in older adults with diabetes, and I'm going to keep this very brief because probably most of the things that I'm going to talk about, one of you have written about that. Talk about what are the barriers to de-prescribing, specifically in diabetes management, and strategies for de-prescribing medications in older adults with diabetes, and particularly what my experience have been and what my thoughts are. So let me start with this case, and this is a real case, 83-year-old independently living Russian-speaking patient with type 2 diabetes for 20 years. Usually, my endocrine colleagues may not be able to tell how difficult this one-liner is, where there is a Russian-speaking patient who is living by herself. So every time you have to communicate with her, you have to have an interpreter, and anything to do with her is not easy. But again, audience here has understanding of what that means. At the time of her clinic visit, her A1C was 8.9%, and she only checks fasting glucose. Multiple times after our discussing why I need numbers at different times of the day, she brings her logbook somewhere between 120 to 160. Most of her readings fall. And her current regimen is basal insulin, 30 units twice a day, mealtime insulin, 10 units twice a day with her two largest meals, metformin, 1,000 milligrams twice a day, and sitagliptin, 100 milligrams once a day. So the question is, do we de-prescribe? And if so, how? This is a patient with the only numbers we have is fasting, which looks fine, but A1C is 8.9. So where do we start and where do we go? So let's go over why de-prescribing is needed. And again, there is plenty of data over past decade. This was a consensus report that was published in 2012, the first time, and it talks about why a A1C goal needs to be different in older adults and why the fasting and preprandial glucose levels need to be different in older adults. And that's not the only organization. Here, the AACE guidelines, ADA, IDF, EDWPOP guidelines, Endocrine Society guidelines, all of them have, in a very detailed and logical way, told us what should be the A1C goals and why we should have different guidance for diabetes care in older adults. In fact, American Geriatric Society have clearly showed us in no uncertain terms, quality of evidence high, strength of recommendation strong, that there are certain medications that are not appropriate for use in older adults with diabetes. So what then is happening in real world? And Kasia Lipska has probably published the most data here, and she has shown that the relatively healthy group, complex intermediate groups, or complex and poor health group, and these are the three groups that most guidelines talk about when talking about glycemic goals. The hemoglobin A1C levels, whether we talk about less than 7 to 8, or more than 9%, they really don't change based on patients' overall health levels, the way it has been recommended. In fact, the medications, whether people are taking any medications, any oral medications, or insulin and sulfonylurea, which are thought to be high-risk medications for hypoglycemia, again, really there is no difference between the groups in the real-world data. And then she has also shown that essentially oldest of old population probably has a more tighter control in the terms of hemoglobin A1C than youngest patients. So in real world, really, we are not seeing what is recommended. And is there then the consequences of that? The FDA had published this group of medications that increases the risk of emergency hospitalization and emergency department visits, and out of the 5 highest risk medications, 2 of them are for diabetes management, and they do affect because the mortality, odds ratio of mortality does increase whether the person is getting mild hypoglycemia or severe hypoglycemia. So I think that the idea is, and again, as I said, you have most of this is done by you, that there is a consequences of not de-prescribing or over-prescribing or over-treatment or whatever word we use, and that the recommendations are not typically seen in a larger picture. So why not? What are the barriers? And many of you, would know, and again, I have talked to many of you, that different clinicians really have different understanding of what de-prescribing means. Second problem is that de-prescribing all medications are really not the same. So when we talk as a geriatricians about narcotics or benzos or antipsychotics, they really need different approach than we talk about the anti-oral hypoglycemic medications. And then my favorite, difficulty with parameters for glycemic goal and solubility of hemoglobin A1C. So I don't know how many of you were on the email talking about when the VA came out with the new guidelines about liberalized goals. And I sort of picked some of some of what was going on and put it more in a neutral way. So if you look at it, people had worries about evidence. The quote was, where is the data that support A1C less than 8.5 is superior to A1C less than 7 for most people, right? There was worried about withholding beneficial intervention. People said, individualized approach to management is absolutely fine, but withholding therapy in those with excellent control is a terrible idea. Or worry about inertia. And that was a little bit tricky, saying that putting the individualization does not equal to most. And I think, as geriatricians, we are saying, but of course we are not saying most, but this is the concern. This is the communication gap. Someone said it is always interesting that when I see physicians with diabetes, they want their control to be perfect and have A1C around 6% or lower. The ACP and many PCPs who cannot achieve these goals have decided to change goals. So that was a little bit frustration there. And then the other quote was easily be used to justify PCP inertia and or drug cost containment by the healthcare system. So as you can imagine, with the diabetes management in particular, there are a lot of stakeholders and there are a lot of people who have different ideas. You have diabetologists, you have geriatricians, you have clinicians, many of them, nurse practitioners, PA, they take care of diabetes, educators, nurses. And then there is a heterogeneous population with older type 1, older type 2, and people who are, the caregivers for this very complicated population. So how do we then communicate? And so when I was thinking about, what do I say? And I talk to geriatricians about diabetes and diabetologists about, geriatrics. And when you talk about de-prescribing to endocrinologists, I felt like it was like a spiritual, what is spirituality, right? It's hard to say what it is. It's easier to say what it is not. So what it is not de-prescribing? It's not giving up. It's not putting people out to pasture. It's not dropping the X at 65. And believe me, these are the exact words I've heard from people who are really, really anxious about this. It is not taking away useful tools. It is not a hospice care. It is not treating all older people like they are unable to do anything intelligent. It is also not letting A1C go higher. And this is probably a tricky part here where even people who are convinced about that end up doing things that are probably not the best way for de-prescribing. It is not letting percentage of duration of time in range lower. Older adults, only 50% is okay. Younger adults, 70% is okay. And then people get really excited about it. That says what? And based on what? It is not taking patients off insulin and sulfonylurea. That is not de-prescribing we need in diabetes. It is not withholding all technologies. And it is not just decreasing the dose or stopping of diabetes medication. And this is sort of a different approach than what we use for, again, narcotics, antipsychotics, benzos, which are traditionally, we are more gung-ho about de-prescribing. And with that, I again have to sort of get over that why letting A1C go is not adequate. We all know that hemoglobin A1C is glycation of the RBC molecule, and then there are various conditions that are commonly seen in older adults that affect the glycation of RBC molecule, primarily because of the change in RBC turnover or change in RBC lifespan. And many of these conditions we do see in the same patient. Problem is the change in A1C. So, the error in A1C levels are actually in different directions with that. And then, of course, with the continuous glucose monitoring, it is so clear that A1C does not identify glycemic excursion. So this is the CGM data on somebody with A1C of 7.3. This is a CGM data on somebody with 7.2. And as you can see, really understanding A1C neither helps me help this patient what to do, nor it helps me decrease the risk of hypoglycemia. So, then the question that typically comes about is that, does it matter? Is it really a problem, and how many of these people have that. And we did this study long time ago. It almost looks primitive at the time, but we found that in 40 people with age over 70 years and A1C over 8%, 26 of the 40 had at least one episode of glucose level under 70 over 3-day period. And 14 of them had A1C between 8 and 9, 12 of them had A1C over 9%, and 46% of this episode went below 50. So, what do we do? Then how do we overcome the barriers? Well, I think thinking about the barriers, different clinicians have different understanding, and we need better explanation, and we need algorithms or how to for people who do understand, but they just have hard time going deeper into the diabetes world to understand how to do that. We need to sort of put up the idea that de-prescribing all medications are not the same, that perhaps de-prescribing or taking away is not the right word for what is needed for diabetes management, and it is more sort of a realigning the strategy rather than taking away the medications. And then we need to be careful with this hemoglobin A1C that there are newer technologies that are getting easier to use by the day, and expense-wise are getting cheaper by the day, in the sense of how much difference is between the measuring A1C on one hand and understanding of say, professional CGM, and we need to use those sort of technology. So I feel like medication de-intensification in many areas, the concept is accepted, but the methods remain confusing. And then comes the words about personalized, resetting, realigning, liberalizing, simplifying. It's really difficult for a primary care physician who understands the concept on what to do about that. So I just wanted to sort of show, Josh Newmiller and I wrote this in 2019, sort of trying to say that in context of diabetes, we probably can use different words for the different goal in patient. So, for example, an 89-year-old patient with coronary artery disease, CHF, and stage renal failure, and recent falls. The patient lives alone, cooks and eats by himself. So, a lot of unknowns here. And then he's on basal bolus insulin regimen due to contraindication to all of other non-insulin medications. And he brings the fingerstick glucose readings that fluctuate between 70 to 150 most of the time. And the hemoglobin A1C is 7.1%. And I have to usually tell people about why the fall history worries me, or why living alone worries me, or why eating by himself worries me. Not to this audience, but the idea is that liberalization is done for people to increase the hemoglobin A1C or glucose goals, and should be done for patients who are unlikely to benefit from tighter control and may be harmed by this tighter control. So I would say in this person, I would first of all avoid A1C dependence because of multiple things that could be drawing his A1C higher or lower. And then focus on this glucose goal and say liberalize the goal between 100 to 200. So try to avoid below 90 and see if we can at least decrease the risk of what happens with his hypoglycemia, if at all he has any. For another example is 81-year-old on 3 antihypertensive medications, 2 lipid-lowering medications. For diabetes, she takes metformin twice a day, glipizide twice a day, and GLP-1 receptor agonist once a day. And when you ask, she forgets, no more than 2 or 3 doses of medications I forget. I take most of them, right? And then she's not really checking finger sticks. Well, this probably requires the intensification to decrease the burden of therapy, and typically thought about in patients with polypharmacy, non-adherence, difficulty coping, having side effects, and we can discontinue all the non-essential medications and try and see if we can use long-acting formulations so there is a less number of times she has to take medication. So in this case, in fact, I might consider adding basal insulin. And so the idea is that insulin is not the enemy, it is how we use it, right? So if I use once a day basal insulin, take away glipizide and metformin, and perhaps use once a week GLP-1 receptor agonist for the postprandial control, then I have decreased the burden of therapy significantly. And that might actually get the barriers, get the barriers out for this particular patient. And then there is simplification. Somebody like 84-year-old patient with type 2 diabetes on bolus insulin for past 25 years, recently hospitalized for stroke, unable to check finger sticks or take multiple insulin injections. She lives with a very supportive family, but they work and not at home during the daytime. So daytime finger sticks and daytime insulin injections are a problem. So this is a patient who requires simplification of strategy to match her coping ability. So this is done when the treatments are overly complex or difficulty following the regimen consistently. And it is done by changing the strategy that is easier for patients or caregivers. So in that, this person, I would probably suggest that basal insulin, take it in the morning. Somebody before going to work can give her that. And then provide non-insulin agents for the postprandial coverage. And this is a little bit complicated because in diabetes world, most of the algorithms are what comes next. Very few people has to worry about how do you go backwards. And so we did this simple study where we took people over age of 70 who were on multiple insulin injections. We checked high stimulated C-peptide just to make sure they were truly type 2. And then our primary outcome was hypoglycemia. So they had to have at least one episode of glucose under 70 at baseline. And then we, for 5 months, we simplified regimens with once a day glargine and non-insulin agents. And then because this was not a randomized control, we let them be on their own for 3 months to see how they maintain their simplified regimen. And what we found was that hypoglycemia duration decreased significantly at 5 months after simplification, and further at 8 months when people were left on their own. But this happened without any significant change in hemoglobin A1C level. And as far as how this sort of algorithm is now as a part of the standard of care of in ADA in older adult section, and it's not really a very complex way of thinking about it. It's simply saying that if somebody is on basal and bolus insulin, or they are on premix, put the basal insulin in the morning. And this is based on studies that we have done where as people get older, their fasting glucose tends to be much lower and they have significant postprandial hyperglycemia at every A1C level. So they do better with basal insulin, where when they are waking up next day morning, their insulin is running out of the steam and there is less chance of overnight hypoglycemia. And then titrate the basal insulin to fasting glucose level with the goal of fasting glucose between 90 and 150 majority of the time, but again, one may change based on overall health goal of that patient. If somebody is on premixed, you consider 70% at the total dose of 70% of the total dose as basal, and then mealtime insulin, you start titrating it down as you start adding non-insulin sort of agents. And I haven't really gone into a detail here. The standard of medical care has very good algorithms and they sort of walk you through that. The only difference is that we go up quickly on the non-insulin agents as we discontinue insulin. I still use metformin fair amount of time as long as EGFR lets me does it, and then otherwise, then we kind of go over with the ADA recommendations. So again, I don't have everybody on my screen, but I'm wondering if many of you were there. We did a sort of a workshop on the prescribing consensus initiative in Boston as the fourth workshop of our International Geriatric Diabetes Society. And the idea was that how do we essentially go over not just why, but how. And how do we communicate with the other clinicians on what we are proposing? And the idea, simple idea, is that all older adults with diabetes should follow guidelines from all these different organizations. We are not talking about every 60, 70, 80-year-old patient, because that's the first thing that makes people sort of put their defenses up. And we are not really talking about all older adults with diabetes. We are talking about older adults with diabetes who are failing their current therapy. And if that is so, then we are proposing realignment of strategy with the 4S framework, sleuthing for the reason for this change. Why, after whatever time, they are suddenly now failing. Shared decision-making, make sure that the patients and their other clinicians are on board, and we explain to them why we are trying to change whatever they have been doing for many years probably. Set and reset the goals based on what else happened in their life, and then simplify. And that is what we are developing our sort of manuscript, and hopefully this will be a useful tool in care of older adults with diabetes. And at the lastly, sort of trying to see how does technology help with treatment decision in older adults, and should we need to use technology? So let me go back to this patient that I saw. If you remember, this Russian-speaking patient who is living alone and on basal insulin 30 units twice a day, mealtime insulin 10 units twice a day, metformin 1000 milligrams twice a day, and sitagliptin 100 milligrams once a day, with A1C of 8.9%. And I did a professional CGM, 2 days of CGM, mass CGM, where patient doesn't have to do anything. She just keeps it on. And here is what here is what we found. So you can see now, without this minor technology where patients doesn't really have to do anything, it's impossible to know what 8.9 means here. So what did I do? So basically, if you look at it, patient is really having high. This is 70 to 180, the green zone. Patient is having high most of the day, and then overnight, she drops. This is midnight to midnight. So right about bedtime, she starts dropping all the way to in the morning. And so I changed her basal insulin from 30 units twice a day to 65 units in the morning, so that this will cover the postprandial better and not so much overnight. Stop the mealtime insulin. I have no idea where that two of the 10 units are going. So let's just not worry about it right now. I don't know whether she's going to need it later on. Change the whole 2000 milligrams of metformin here in the morning, because she needs a lot more coverage postprandially, not so much overnight. And then discontinued sitagliptin, because it's really have a minimum impact when we are using such a large dose of insulin. So in summary, I would say that in my opinion, why do we need to consider de-prescribing in diabetes when the risk of current therapy essentially outweighs the benefits? It's not even so much about glycemic goals, it's about current therapy. What are the barriers to de-prescribing specifically in diabetes management? I think miscommunication regarding the intent within the providers and between the clinician and their patient, I feel like is a major barrier. And then lack of clear algorithms to do what we need to do. And then strategies for de-prescribing medications in older adults need deliberate changes in the strategy to overcome the patient-specific barriers And then hopefully the 4S framework will provide something that the clinician can think more deliberately rather than sort of a broad sort of thinking about that. And then I always sort of live with this aging successfully. You know, Dr. Joslin, I mean, one of the things that he was very strict and in those days needed patients to do what they needed to do to control their diabetes. However, this is him at the age of 91 on the steps of newly built Joslin Clinic. This is at the age of 90 on horseback. He passed away at the age of 92. So this is what he personifies. He showed by behavior that this is what most people want, and we shouldn't really get into the numbers so much that we forget the big picture. And with that, I thank you for your time, and I'm happy to take any questions, comments, and your thoughts.
Thank you, Dr. Munshi. Please type questions in the Q&A bubble icon on the bottom of your screen, and we can let people have a chance to do that. I also welcome questions and discussion from our esteemed panelists. I wonder if you could start with, and I think you started with this, but about communication barriers and language and between clinicians and patients. What do you think about how do we overcome those challenges, communication barriers?
Well, I think my way of talking about to the patient especially is that they when you say that I want to change and they don't know the logic behind it, I think that's what bothers them the most. And I think telling them that we are not changing the goals, we are still trying to do the best glycemic control without risk of hypoglycemia. We are simply changing the way we do it so it's safer for you. And I think that again also is very different from different barriers. So identifying where the problem is and then sort of talking them through might be that is actually, I think, is trying to get over this word de-prescribing, which seems to be bothering them.
Right. And okay. Other comments or questions, feel free to put them in the Q&A. I think another which I think is a focus of your research, another topic is about technology. And I wondered if you could say for the audience a little bit more about, when you use more advanced technologies, monitoring technologies, what's available and what, maybe this is a longer, another talk, but in what's coming down, what should we expect in the future?
Yeah, I think, I would tell you that 10 years ago, I was sort of, if somebody would come to me in my clinic at Joslin and talk about the technology, and I would say, hey, I'm a geriatrician, I'm not your doctor, you have other people. I think the technology really has become a lot more user-friendly and a lot more understanding of what we need. So CGM, I think continuous glucose monitoring is probably something that I think all our older patients, and frailer they are and more cognitively, more cognitive challenges they have, I think they would be useful. And because especially those who are on sulfonylurea or insulin, and these are the masked sensors that you apply it in your clinic for the patient. They go home, they have to not do anything, there is no calibration, and then they peel it off like a Band-Aid and mail it back to you, and we see the patterns that you saw on some of these pictures. So that not only provides whether patient has, whether patients are in good control or not, but also what to do about it. If you see a dip, huge dip and huge high, it tells you exactly where you need to change your medications, unlike A1C. So if I give up 4 A1Cs and do 2 of those professional CGM a year, the cost-wise, I don't know what that means, but that certainly would help me to treat my patients better. And then how many times we tell people to do finger sticks and they come back and, they don't have it. I forgot my meter. I forgot my paper. I didn't do it. I forgot. It's such a waste of the clinic visit to where we could have helped them. So, I would say that is probably the lowest hanging fruit, the professional CGM.
Mhm. Great. We have a question from Joshua Kiptu, which is, in settings where de-prescribing is not practiced, any advice on how to best start the discussion among clinicians and or patients? So in places where de-prescribing is not observed or practiced, it's not part of their culture.
Yeah, I think that was my, that is my worry, that I think I think it's a word matters. I think it's saying that what we mean by de-prescribing, and I think I was telling some of my colleagues that I have never seen geriatricians or primary care physicians and endocrinologists at odds with the idea against each other, as I've seen with this concept of de-prescribing. And I really think that to tell them that we are not taking it away, I think the same thing that I was discussing, and then give them. So what we are hoping to do with the manuscript, with this after workshop, is to actually not just talk about why, but how to. So have some simplified way of thinking about it, that how do you simplify? Because again, simplification in older as type 2, with type 1, those who are in the nursing home, we are really living in a good times where we have so many tools to manage diabetes. But that's what is actually becoming a barrier for primary care physicians to actually work with that, because they don't know what this is, and I don't know what to do with this. So we need a better algorithm. We need a better decision trees to help them.
The simplification benefits the prescriber as well. Maybe.
Right. We all need simplification in life, everywhere.
Question from Lisa McCarthy, which is, can you talk more about the use of CGM for residents in nursing homes or care homes?
Hi, Lisa. Yeah, so I think, as you know, it is not approved for use in a nursing home and care homes here in US. I'm not sure in Canada whether it's approved or not, but I truly believe that is going to be a tremendous benefit. There are several things, and we are trying to do this study, observational study, for last 3 years to just understand the scope of the problem. But with the COVID and the nursing homes, it's just impossible to have data on that. But in my mind, there are 2 ways that it can help. One is that there are a lot of times that finger stick readings becomes a problem, especially those individuals who are cognitively sort of impaired, and trying to tell them that you need that's a problem. And so if you have a non-invasive way of understanding the glucose levels, you can improve glycemic control, but more importantly, decrease the hypoglycemia in people who are refusing to eat or refusing to take medications, or the activity is not consistent. And the second thing is that if COVID has shown us something, it has shown us the importance of infection control when the staff takes care of the patients. I mean, that's how it's spread. So imagine something where you don't really need that kind of close contact with the patients for 4 times a day. Now, I understand the other side of it about isolation and not talking to the patient. That's not what we are talking about. We are talking about the data needed to take care of the patient and how much closer interaction they need in the nursing home. And if we can avoid it and prevent a little less, or decrease the risk of these outbreaks, that's a reasonable way of thinking about it.
On the subject of hypoglycemia from Mike Steinman, so the recommendation to avoid A1C targets and treat symptoms in older adults with poor health. How do you assess whether symptoms are related to glycemic excursions if you don't do finger sticks or CGM?
Well, it's really that's probably the biggest problem. There is no way. And my worry is that you can't even depend on the symptoms. The study that we did even in 2011, 98% of our patients did not actually feel all the symptoms when we saw that on CGM. And, the neuroglycopenic symptoms or hypoglycemic unawareness is rampant. Even people who say that they feel it, they don't feel it consistently. So it's hard to depend on the symptoms. And then my worry is that first the patient have to recognize typical or atypical symptoms as coming from hypoglycemia. Then they have to remember them that happened yesterday or last month. And then they have to remember to tell us about it, that it happened, 3 months ago. And so the reporting of symptoms is so unreliable that I worry that symptoms are probably not the best way to recognize or prevent hypoglycemia. So that's why I think CGM is such a critical tool to do so, and doesn't have to be done all the time. The CGM for professional CGM is one thing. In fact, when I talk to my endocrine colleagues about professional CGM, they think I'm crazy because they say, why wouldn't you use personal CGM where patients can scan that and look at the numbers, and it gives them so much more information, and they can do something about it. So why would you not do that? And then I argue with them that there are many patients in my practice that does not want or cannot do anything with that information. So, professional CGM gives me the pattern to help them. But that's, again, that will sort out as we go along and things get easier.
We have a question from a primary care pharmacist in Spain who is working on de-intensification of diabetes treatment in older patients, 75 years and older. They have a lot of patients with A1C very low, less than 5%, and yet prescribers are still worried about de-intensifying. So how do you convince them that, I guess, more is not always more?
Why would what would they intensify to?
Sorry?
I'm not sure what they would intensify that to. That the finger stick numbers are high. I mean, certainly 5.7, you can't intensify the A1C. So I'm not sure exactly perhaps what they are intensifying. Are they trying to look at the finger stick that does not match perhaps the A1C? That might be a problem.
Okay. Well, we'll give that person a chance to clarify. We have another question, which is a patient who was on premixed insulin and metformin saw a naturopath doctor and dietitian as part of her healthcare team and was introduced to a diabetic diet. how would you plan for med adjustments for a patient who's going to adapt a diabetic diet?
Over past 10 years, I haven't heard diabetic diet actually. I don't know what that is. I mean, every diet has carbohydrate. I mean, we have really gotten away from diabetic diet, even in the long-term care facilities. So it's not really a concept that I don't even know what that means. But basically, I'll tell you what I do when I see my patients, that I tell them that they have to spread. It doesn't matter what diet they are using. But if they are taking medications for diabetes, they need to spread their carbohydrates throughout the day. The problem is that there is so much of the PR going on about what is healthy, what is not, that it's very hard for older patients to grasp all these different nuances. So somebody says, well, I eat a whole, oatmeal is good for my heart, right? Yeah, that's good for my heart. And then there is the blueberries in there because that's good for my heart. And then, you ate a other bowl of fruits and berries, and then the blood sugar goes sky high after breakfast. And then they have a salad for lunch. There is no carbohydrate, so it drops down. It's just to help them understand what the carbs are and how do you spread it so that you are not bouncing around. Actually, I feel like, and this is not approved, but I feel like the best use of that intermittent CGM that we all watch on the television where you scan it, the best use of that is in people with pre-diabetes or people who are really having hard time with their diet, because they can exactly see what happens when they eat 10 grapes, how that goes up, or when they have a whole bowl of salad and how it goes down. That's the best way to learn what different types of food items does to your own glucose levels. I don't know if I have better answer than that.
Okay. Do you have any comments on symptoms of hyperglycemia that, in your clinical experience?
That's a question we are all struggling with, that we are so focused on hypoglycemia that we really don't understand what happens with hyperglycemia. I think and that's why I think I'm talking about we as in geriatricians, we are not saying that we only should prevent hypoglycemia. We are saying that the best control we can get without hypoglycemia. So, to the flip side of that is that when you see that patient that I showed you, where there is a low blood sugar and high blood sugar, so she's going from 40 to 400, she's not only getting long-term and short-term complications of hyper and hypoglycemia, but feeling symptoms of hypo and hyperglycemia. And I think that, I don't think there is a whole lot of, the most I hear about hyperglycemia symptoms is people with type 1 diabetes. They are very sensitive to their high glucose levels, and I work with them over months to help them sort of say that, that's true that you are not feeling well with blood sugar in 200 and that you don't even feel you're 50, but that's not really good for you. So, sort of try to come in the balance. But it's a good question, and I don't think we have enough data on that.
We have a few minutes for any additional questions. And if not, thank you, Dr. Munshi. This is really wonderful, and thanks for leaving lots of time for questions and answers. Really important topic. And thank you to all our attendees as well. We do have a recording, and that will be posted on the US De-prescribing Research Network website. And when we sign off, you will receive a evaluation survey by email. And if there's no other comments or questions, thank you everybody again, and have a great rest of your day.